Now we are back. The next interesting section, Rising Star Awards in Asia Pacific 2022. May I call on stage Professor Andrew Chan from Harvard University, USA, and Professor Ratha-korn Vilaichone from Thammasat University, Thailand. Please join me welcoming.
So when we talk about the research topics, the people maybe want to get interest outside more than inside the meeting. The main objections to set the ASEAN Pacific Rising Star, we'd like to get the young smart doctors who have a very good productions going to be present their research topic, and we believe that in the near future, maybe all of them is going to become the international speakers. And we already provide the grants, the travel grants to be here for 5 countries as a representative. And we're going to start first with Andy, please.
Yes, so very pleased to be able to introduce these rising stars, the future of our field. The first rising star I'd like to bring to the podium is Dr. Tzu-Chan from National Taiwan University Hospital Cancer Center. He is a graduate of National Taiwan University, where he received his medical degree and PhD. He also trained in internal medicine at National Taiwan University and was a fellow in gastroenterology at the same institution. He's been a very productive young investigator with now several first author publications and also presenting many important topics at the Taiwan Digestive Disease Week and the Asian Pacific Association for the Study of Liver. So today he is here to present his work on the primary antibiotic resistance of Helicobacter pylori, trends in Asia Pacific area, and update of systematic review and meta-analysis.
Okay, thank you, Dr. Chan, for your kind introduction. And moderators and ladies and gentlemen, I'm Tzu-Chan from National Taiwan University Cancer Center, and I'm going to talk to you about the primary antibiotic resistance of H. pylori, the trends in Asia Pacific area, which is an update of our previous systemic review and meta-analysis. I'm going to cover the importance of H. pylori antibiotic resistance and also the current evidence before this study, also the searching strategy and selection criteria of this study, and 3 key questions and answers in this study. Also to discuss about the limitations and implications of this study. As we all know, H. pylori eradication is currently treated with certain empirical antibiotic regimens, especially in areas without resistant tests. The effectiveness of these regimens is largely depends on bacterial antibiotic resistance. The regional antibiotic resistant pattern is crucial to plan treatment strategies. There are 11 meta-analyses before this study, which study about the country, region, and worldwide resistance of these antibiotics. And we would like to concentrate particularly on our previous studies in 2017, which is the Asia Pacific region study, and showing that the increasing of 3 antibiotics, clarithromycin, metronidazole, and levofloxacin. However, there is no obvious increase in the last period, and also lack of the more recent data limiting its use currently. Hence, the aims of this study is to update and summarize the prevalence and trend of antibiotic resistance in previous analyzed period, and also to extend our study period with another 5-year interval. The searching strategy is including the primary resistance of H. pylori to commonly used antibiotics. And we search PubMed, Embase, and Cochrane trials written in English, and observational studies and randomized controlled trials were included. Publications from 2016 and until 2021, with the study periods extend from 2016 to 2020. And there are a total of 291 studies, combining from 176 of our previous review and also 115 of the new studies. Our first question is, what is the updated overall resistance of individual antibiotics? And we can see that the clarithromycin is 20%, metronidazole 50%, levofloxacin 24%, and tetracycline 3%, and amoxicillin 4%. However, are these summary data the best estimates in practice? Let's see about the trends of the antibiotic resistance. And the rising trend showing that the resistance of clarithromycin increased from 7% to 28%, and the resistance of levofloxacin increased from 8% to 33%, and also the metronidazole increased from 37% to 57%. However, another two antibiotics, amoxicillin and tetracycline, remain stable around 4 to 5%. Hence, the updates modify and emphasize the rising trend of certain antibiotics which provide current resistance by periods. Our next question is, what are the country-specific resistances? This is the resistance of clarithromycin in this area. On the right-hand side, this is the resistance by country and by trends. And we summarize the most recent antibiotic resistance on the left-hand side, with the resistance of clarithromycin more than 15% showing in red, and below 15% showing in green. More than half of the countries have the clarithromycin resistance higher than 15% here. And this is the metronidazole resistance of individual country. As you can see on the left-hand side, most of the countries have the metronidazole resistance above 40%, showing in red. For levofloxacin resistance, about half of the countries were showing in green, which is lower than 20%, and give us an idea of using levofloxacin-based treatment may be useful in this country if clarithromycin resistance is high. For tetracycline resistance, most of the countries are low in resistance, except for India, Iran, Mongolia, and Vietnam, which has the resistance above 10%. And it is the same for amoxicillin. Only countries like Iran, Korea, Mongolia, and Saudi Arabia has resistance above 10%. The individual countries show different antibiotic resistance patterns in different periods. Hence, our next question is, what are the countries with high clarithromycin and metronidazole resistance, which is crucial to empirical regimens like concomitant therapy and sequential therapy? On the left-hand side is the overall resistance of clarithromycin and metronidazole in different countries. On the right-hand side is the most recent resistances, with the clarithromycin resistant on the x-axis and the metronidazole resistant on the y-axis. Only few countries were located on the left lower quadrant, indicating that most of the countries have at least one of the resistance to key antibiotics above threshold of high resistance. In discussion, the regional and country-specific antibiotic resistance were rising to an alarming level now, and pooling of regional data is not the best estimate practically. The susceptibility tests rather than empirical combinations for formulating adequate H. pylori eradication regimen will be more important in the near future. However, there are some limitations of this study because of the high between group heterogeneity due to significant differences of resistance across different countries. Also, we cannot address regional differences in a country. And there is still lacking some information of different periods in certain countries due to publication bias. And we did not address dual, triple, or quadruple resistances due to high frequency of variable sample sizes and limited information in studies. Ladies and gentlemen, the implication and future direction after this study is that the information about temporal and regional differences is crucial to prescribe optimal first-line therapy in area and surfaces lacking proper H. pylori culture and drug sensitivity tests. However, the antibiotic resistance surveillance should be implanted in practice for local resistant pattern before susceptibility testing popularized. This is my talk. Thank you, and thank for the mentors, Dr. Lin, Wu, and Liu.
So we have a few minutes for questions. Any questions for Dr. Hong? So there's one question online. The question is, why in different countries there's a wide variety of patterns of ATB resistance?
The question is, in a country or across different countries, there are a wide variety of antibiotic resistance.
So I think that the questions maybe mean that why is it have a very different varieties of the antibiotic resistance in different countries. Some countries may be low keratомycin resistant. Some countries may be very high.
I think it may be impacted by the use of antibiotics locally, and also the use of antibiotic both in human and also in agricultural area.
A second question is, why do we use, because we use a lot of amoxicillin, why is it that the resistance to amoxicillin still is low? Any theories as to why that is?
Okay, the answer may be because of the mechanism of antibiotic resistance, like clarithromycin and levofloxacin. When the antibiotic resistance develop, there's only like 1 or 2 key mutations in like DNA drivers or like ribosomal RNA. But the mechanisms of other antibiotic resistance is like multiple mutations or like through different ways of resistances.
Maybe I can add a question. So, you mentioned this as one of your limitations, but is there a sense that you have that some of the resistance patterns seen in different parts of the world may have to do more with differential reporting as opposed to true resistance?
Pardon for the question?
Do you have a feeling that maybe some of the differences that we see in different countries may be more an artifact of the country's ability to track resistance and report resistance as opposed to true resistance?
Yeah, like the publication bias
Yes.
I mentioned earlier, because there's some like crucial periods in some of the countries, lack of resistant data.
Okay, thank you very much. So our next rising star will be presented by Zoom. That's Dr. Arti Wongcha-um. He's from Canada. He is a graduate of the University of Southampton Medical School in the UK, and he has been in a gastroenterology and hepatology fellowship at McGill University in Montreal, Canada. He is going to be presenting his work on therapeutic drug monitoring of biologics in IBD, when, how, and for whom.
Hello, ladies and gentlemen. My name is Arti Wongcha-um, and today I am going to be providing a brief talk on therapeutic drug monitoring of biologics in inflammatory bowel disease, when, how, and for whom. I would like to thank Professor Fief, my supervisor, for allowing me to review this topic, and Professor Ratha-korn Vilaichone for giving me the opportunity to present at this event. Biologics have revolutionized the management of patients with IBD in both Crohn's and ulcerative colitis. There are several classes of biologics used to treat the disease, including anti-TNF agents such as infliximab and adalimumab, and non-anti-TNF agents such as vedolizumab and ustekinumab, with many others still in development. Despite their effectiveness in treating the disease, about 30% of patients are primary non-responders, and another 50% lose therapeutic benefits over time. Therapeutic drug monitoring, or TDM, provides a tool for biologic dose optimization consisting of two components. One is by measuring the drug trough concentrations, and two is by measuring anti-drug antibodies. Drug concentrations are positively correlated to therapeutic benefits, but questions remain on how, when, and for whom to perform TDM. Target concentrations vary depending on many factors. Many exposure-response relationship studies have shown that higher biologic concentrations are associated with better therapeutic outcomes during both induction and remission. The desirable thresholds vary depending on different therapeutic outcomes being investigated, i.e. clinical remission versus biochemical response, or endoscopic remission versus histological remission. However, most of the data available are on infliximab and adalimumab. Generally, more rigorous outcomes such as endoscopic or histological remission require higher drug threshold. Features of high disease burden such as severe acute ulcerative colitis and fistulizing Crohn's disease require even higher thresholds. To back this up, this table provides a snapshot of data published in the latest expert consensus published in the American Journal of Gastroenterology, showing that drug thresholds from different studies on anti-TNFs vary depending on the desirable therapeutic outcomes. TDM can be divided into two parts, reactive and proactive. Reactive TDM is done in the context of biologic treatment failure to provide guidance for drug optimization if the drug concentration is inadequate in the absence of anti-drug antibody. Dose optimization is needed, whereas if the drug concentration is high with the presence of high anti-drug antibody, switching biologic is needed. In contrast, proactive TDM is done at particular intervals where there is no apparent loss of response in order to enhance response rate and prevent treatment failure by determining whether the biologic dose is optimized. To expand this, here is an algorithm for reactive TDM. So if you have IBD patients with loss of response, i.e. worsening clinical symptoms where active inflammatory disease is confirmed, if the drug concentration is considered therapeutic with a detectable anti-drug antibody, this suggests a mechanistic failure where switching out of biologic class is needed and adding an immunosuppressant may help reduce immunogenicity. Whereas if you have a therapeutic drug level with an undetectable anti-drug antibody, this suggests a purely mechanistic failure of the drug where switching out of biologic class is needed. On the other hand, if you have a subtherapeutic drug level with a detectable anti-drug antibody, this suggests an immune-mediated pharmacokinetic failure where switching in class is needed and adding an immunosuppressant may help. And if you have a subtherapeutic drug level with an undetectable anti-drug antibody, this suggests an inadequate drug concentration and dose optimization is needed. Most recommendations and guidelines are in favor of using reactive TDM in primary non-responders and secondary loss of response to anti-TNF biologics, although most of the current evidence on reactive TDM is only available on anti-TNF biologic. Its role for non-anti-TNF biologics is supported by exposure outcome studies showing that higher concentrations of vedolizumab and ustekinumab are associated with better therapeutic outcomes. Hence, the latest expert consensus published in the American Journal of Gastroenterology recommends reactive TDM for all biologics. Here is a snapshot of the latest expert consensus statements recommending the use of reactive TDM for all biologics. Although data is still relatively limited to reactive TDM, evidence suggests superiority of reactive TDM in anti-TNF therapies when compared to empirical dose escalation and reactive TDM. Strong evidence exists to support the use of reactive TDM routinely in several situations, such as cases of severe UC, fistulating perianal Crohn's disease, pediatric IBD, and IBD in pregnancy. For example, in fistulating Crohn's disease, fistula closure requires higher infliximab concentration of greater than 10 micrograms per mils versus just 3 to 7 for luminal Crohn's disease. It is too early for proactive TDM algorithms to be widely applied, as much high-level evidence is still lacking in several aspects. For example, studies on other biologics other than anti-TNF therapies and optimal therapeutic drug concentrations to target, depending on various therapeutic outcomes. Until recently, the recommendations made for routine use of proactive TDM by various medical societies have been vague due to insufficient data, but the most recent expert consensus published in the American Journal of Gastroenterology has provided the clearest statement on proactive TDM thus far. Strong recommendations were made for performing proactive TDM at induction and at least once in maintenance for anti-TNF optimization. Reactive and proactive TDM measure drug trough and anti-drug antibody concentration, which provides only two components in an individual's multifactorial pharmacokinetic interactions and are prone to lag between testing and dose adjustment. In recent years, a dashboard software-guided dosing system has been developed to determine an individual's precise target trough levels, incorporating TDM with population's pharmacokinetic data, individual factors such as sex, body, weight, and other clinical parameters such as albumin level and C-reactive protein. Other areas to consider as part of the future development of the dashboard system include genetics, where carriers of the HLA-DQ-A105 are more likely to develop anti-drug antibodies, mode of drug administration, subcutaneous versus IV, as well as new technology for TDM, point-of-care home testing, which will allow more rapid decision-making. TDM represents a small part of the dashboard, but moving towards a more personalized approach, it may still play an important part in the foreseeable future with the development of many new biologics and better understanding of their pharmacokinetics. So in summary, Mr. Chairman, ladies and gentlemen, reactive TDM is performed in the context of failure in treatment, and emerging evidence is supporting its use for all biologics. On the other hand, for proactive TDM, it is performed at intervals, not in response to a failure in treatment, with the aim to enhance response rate and prevent treatment failure. But more data is needed to support its use in biologics other than anti-TNFs. The future of TDM use may head towards a more personalized, dashboard-driven approach, taking into account individual factors and combining them with TDM to optimize biologic drug concentrations. Thank you very much for your kind attention. Please feel free to ask any questions.
So our next rising star is Dr. Mai Ngoc Luu from Vietnam. She is a lecturer in the Department of Internal Medicine at the University of Medicine and Pharmacy of Ho Chi Minh City, Vietnam. She's also an attending physician in the Department of Gastroenterology at Nan Yan Ji Din Hospital in Ho Chi Minh City, and an endoscopist at the University Medical Center Hospital in Ho Chi Minh City, Vietnam. Her major interests are in general gastroenterology, hepatology, and endoscopy, with a special interest in Helicobacter pylori, functional GI disorders, GERD, gastric cancer, and colon cancer. And today she will speak about the prevalence of functional gastrointestinal disorders, mental health conditions, and Helicobacter pylori infection among Vietnamese medical students.
Thank you, Professor Chen, for your kind introduction. Dear Mr. Chairman, dear ladies and gentlemen, it is a great honor for me today to present the topic functional gastrointestinal disorders, mental health conditions, and Helicobacter pylori infection among Vietnamese new entry medical students. My presentation outline includes 5 parts. Firstly, I would like to mention some overview of the functional gastrointestinal disorder. As you have known, this disorder are among the most common GI disorder in the community, which affect up to 40% of general population worldwide. And this disorder occur not only in the elderly, but also in children and adolescents. Although this disorder were characterized by persistent and recurring GI symptoms, there is no demonstrable pathology on conventional testing. And up to now, there have been more than 20 subtypes of FGIDs have been identified. However, functional dyspepsia and irritable bowel syndrome are the most common subtypes. There are several risk factors of FGID which has been reported in several reports, including diet patterns, psychological disorder, sleeping situation, and lifestyle habits. The interaction between FGIDs and mental health conditions have been reported in many reports. And besides that, the interaction of the FGIDs and Helicobacter pylori infection were also mentioned in recent study. However, they also have some conflict findings in the literature between the interaction of three aspects: FGIDs, mental health condition, and H. pylori infection. So the question is that what is the prevalence of FGIDs, mental health conditions, and H. pylori in the young adult population? Until now, there has been one meta-analysis from 26 studies reported that the overall FGID prevalence among the students range from about 10 to 30%. A recent study from ASEAN countries shown an increasing prevalence of FGIDs. However, the prevalence in Vietnamese population is still unknown. And due to cultural differences between countries, the factors associated with FGIDs in the Vietnamese population have not been well understood, especially in the young adult population. As a result, we conduct this study with the two objectives. Firstly, we would like to evaluate the prevalence of FGIDs, mental health disorders, and H. pylori infection among Vietnamese new entry medical students. Secondly, we would like to identify the association between FGIDs, mental health disorder, and H. pylori infection among Vietnamese new entry medical students. The reason why we recruit the new entry medical student is because at the time of this study, these students was the freshmen and they have not experienced the pressure of the learning process. So the finding from this study can reflect the true findings of the prevalence of FGID, mental health disorder, and H. pylori infection among the young population in Vietnam. This is a cross-sectional study conducted from November 2021 to March 2022 among new entry medical students at University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam. We delivered the printed survey questionnaire to all of the new entry medical students at the day of freshman health screening at the beginning of the academic year 2021 and 2022. We also collected their urine samples to screen for H. pylori infection using rapid urinary tests. The survey questionnaire included 5 parts, including demographic characteristics, lifestyle habits, sleeping habits, GI symptoms, and we also evaluate their mental health status using the two scale, Generalized Anxiety Disorder Assessment and the Patient Health Questionnaire 9. This is the urinary rapid test. We use Rabirun H. pylori antibody stick from the Otsuka, Japan. As you can see, this urinary test has been validated previously in Vietnamese population with a high sensitivity and the specificity. In the picture, you can see that if the appearance of two red lights, that's the positive test, and if they only the control light appear, so the test is negative, and if the absence of the control light, so the test is invalid. For the diagnosis criteria, we diagnose FGID using Rome 4 criteria. And as FD and IBS were the two most common subtypes of FGID, in this study we only focus on these two subtypes. We also evaluate the presence of gastroesophageal reflux disease using the prevalence of typical reflux symptom, regurgitation, and heartburn at least twice a week. And for the anxiety disorder and major depression, we use the cutoff 10 of the GAT-7 scale and the cutoff 10 of PHQ-9. Among 490 new entry medical students invited to participate in the survey questionnaire, there were a total of 400 valid responses. And here is the prevalence of FGID in our sample study. You can see that FGID were relatively common among the new entry medical students, accounting for 10.3%. And compared to other study, our study findings is similar with the study from Tanzania, Europe, North America, Latin America, and China, but a little lower than the findings from the study of Royal, because this study was conducted on the medical, nursing, and humanities students when the students have passed the process of study, so it can increase the prevalence of FGID among them. And for the overlap GI disorder, we also observed that up to 3% of students had overlap syndrome, and the most common type of overlap syndrome was the overlap between FD and IBS, accounting for 1.8%. How about the mental health condition? We found that the mental health condition were present common among the new entry medical students with the prevalence of 12.5%. And the urinary test was positive in 45%. To evaluate the association between FGID, mental health condition, and H. pylori infection, we compare the two groups, the FGID group and non-FGID group. And we found that, sorry. Okay. Yes, you can. Okay. Okay. Yeah. I want to point here. Okay. Sorry. You can see on the table that the proportion of anxiety disorder and the proportion of major depression were higher in the FGID group compared to the non-FGID group. However, the urine tests were not different between these two groups. This research shows that there is an association between the FGID and mental health condition among the new entry medical students. So the question is there a different effect of the different mental health condition on different FGID? To answer that question, we compare the two groups of anxiety disorder and non-anxiety disorder. Here you can see that the proportion of GERD and FGID were higher among the anxiety group compared to non-anxiety group. Even with the GERD alone and IBS alone, you can see that the proportion of GERD alone and IBS alone were higher in the anxiety disorder group compared to non-anxiety disorder group. This finding shows that there is an association between the GERD and IBS with the anxiety disorder. However, there is no difference of the FD alone and the all of the type of overlap GI disorder compare between anxiety and non-anxiety groups. How about the major depression? You can see on this table, all of group with GERD, FGID, and overlap GI disorder are different between these two groups. However, when we perform a specific analysis for the GI disorder alone, GERD alone, FD alone, or IBS alone, you can see that only GERD alone and FD alone are different between these two groups. However, when we compare the IBS alone, you can see that the IBS alone is not different between these two groups. These findings show that only the FD is associated with the major depression, but not the IBS. Compared to the last slide, you can see that only the IBS were associated with anxiety, but not the FD. We also performed a multivariable logistic regression model, and we found that there are two risk factors of the FGID among new entry medical students, including the habit of sleeping after midnight and the depression, with the odds ratio of the habit of sleeping after midnight were 2.4 and the depression with the odds ratio of 5.5. And we also compare the multivariable logistic regression model for the overlap syndrome among new entry medical students and found that major depression was an independently associated factor of OS among new entry medical students with a high odds ratio. In conclusion, I would like to summarize some findings from our study that FGID and anxiety disorder or major depression are relatively common among the new entry medical students. And the sleeping after midnight or major depression may increase the risk of FGID among new entry medical students. Our study has some limitation. Firstly, that we only screen for H. pylori infection using rapid urinary tests, and the FGIDs were only diagnosed based on clinical criteria without diagnostic endoscopy. However, our study provides some preliminary results to provide the association between the FGID and the mental health disorder among the new entry medical students and the young population in Vietnam. So our research can help the physicians to pay more attention to screen and manage the mental health conditions when dealing with the FGID among young population. Thank you for your listening.
Thank you very much. We only have time for one question, so this is from the online. Was there any response when you treated the H. pylori in the functional GI disorders or the functional GERD patients?
Pardon, can you repeat the questions?
Was there any response when you treated the H. pylori for the people that were H. pylori positive, if they had functional GERD or functional GI disorder?
Yes. According to these recent guidelines, the H. pylori infection should be treated among the individual with the functional dyspepsia. And if their symptoms did not relieve, so we can treat the functional dyspepsia as a functional GI disorder. And if after eradication of HP, all of their symptoms were relieved, so we will conclude that their symptoms were due to the H. pylori infection.
Thank you very much.
And next, we're going to have a rising star from Thailand. It's Dr. Natsuda Aumpan. Right now, so Dr. Natsuda is going to be junior colleagues at the Thammasat University Hospital at the Department of Medicine in the divisions of gastroenterology. Dr. Natsuda is going to have 10 publications in the high standard journal in the past few years. And now her interest is going to go to the functional GI disease and also with the FMT in the clinical practice. Dr. Natsuda, please.
Thank you, Professor Ratha-korn, for your kind introduction. Mr. Chairman, ladies and gentlemen, I am Dr. Natsuda Aumpan from GI unit at Thammasat University, Thailand. Today, I am going to touch on the research topic of the effect of fecal microbiota transplantation on irritable bowel syndrome. This is a double-blind randomized placebo-controlled study. IBS is a common functional bowel disorder. Dysbiosis, potentially contributes to the pathogenesis of IBS. FMT is the administration of fecal solution from a healthy donor into the intestinal tract of a recipient. FMT could be a possible treatment option to restore normal gut microbiota in IBS patients. FMT has provided benefits in patients with IBS in some previous studies. However, most of previous studies used colonoscopy or other invasive techniques. This study aimed to compare efficacy of FMT with placebo via rectal enema in IBS patients. This study design is DBRCT. We included Thai patients aged from 18 to 70 years old with IBS diagnosed by Rome-4 criteria at Thammasat University Hospital between April 2021 and January 2022. We use our donor screening protocol for FMT. Our stool bank was established in 2019 for centralized facility for donor screening. All donors provide informed consent and have to pass both clinical assessment and laboratory screening. Our stool bank is certified by Biosafety Level 2. The donor stool was kept in deep freezer. When using, it was stored to room temperature, then mixed with 200 cc of saline. We remove fecal material and debris before using the FMT. Then the fecal solution was in 4 syringes, which were labeled and carefully packaged for fecal material transportation to ensure that there was no leakage or smell coming out. Then we administered FMT or placebo to a patient by rectal enema by completely covered syringes. We excluded patients such as pregnant women and severe comorbidities. Then patients were randomized 1-to-1 to receive FMT or saline by rectal enema. We recorded Bristol Stool Scale, IBS Symptom Severity Score or IBS SSS, Quality of Life Score at baseline and after treatment. And we also recorded adverse events after FMT. The primary objective was to evaluate IBS SSS at 4 weeks after receiving FMT or placebo. Secondary objectives were to evaluate quality of life score in patients receiving FMT or placebo and to record adverse events during and after treatment. All data were analyzed by SPSS version 22. All patients provide written informed consent before entering the study. For Table 1, there was no difference in the baseline characteristics between 2 groups. For Table 2, there was a significant improvement in IBS SSS at 4 weeks, overall response at 2 and 4 weeks, abdominal pain at 2 and 4 weeks, abdominal distension at 4 weeks, and quality of life at 4 weeks. Figures demonstrated that the IBS SSS overall response and quality of life score were all significantly improved in the FMT group than the placebo group. Clinical factors such as abdominal pain and abdominal distension were significantly better in FMT than the placebo group. Only minor adverse events were reported and no serious adverse events was observed. This is a pioneer double-blind randomized placebo-controlled study on FMT enema for IBS patients in ASEAN. Prior studies demonstrated improvement of IBS symptoms after FMT by invasive procedures. Our study provided significant improvement of IBS symptoms by using less invasive FMT technique. For our next study, we are going to use the oral preparation of the encapsulated freeze-dry microbiota for patients with IBS and obesity. Mr. Chairman, ladies and gentlemen, for my summary, FMT where rectal enema is highly effective and simple way to perform without serious adverse event for IBS patients. FMT is a microbiota-based medicine which has true clinical potential and personalized approach, resulting in better and safer therapeutic outcomes for IBS treatment in the near future. Thank you for your kind attention, and I feel very honored to answer all of your questions.
So they have one question from the online audience. What is the main actions of the FMT for treatment in the patients with the IBS?
The main mechanism of the FMT for treatment of IBS patient, I think, might be related to the gut-brain axis and dysbiosis. As we learned from this morning that dysbiosis might be one of major causes of IBS. So if we use the FMT from healthy donor with healthy microbiota profile, we might use this for treatment of IBS in the near future.
So maybe Andy, please.
Thanks. That was a very nice study. Can you tell me, have you examined the patients more recently? Like, do you think there's a durable effect even beyond 4 weeks?
Oh, I have I have follow-up patient for a longer period at 3 months and 6 months after the FMT. And we can say that the durability of the FMT right now is at least 6 months. And we will follow up patient for 1 year after.
And they're still doing better?
For one year, some patients have less effect from the FMT, and the symptoms of IBS are worsening at 1 year.
And do you think that you would treat them again, maybe, to see if you can induce another response?
There might be a repeated dose of FMT in the near future.
If no questions, thank you so much, Dr. Aumpan. So the last not least, gonna go to the rising star from Indonesia, so Dr. Judith Ratha-korn. Dr. Judith Ratha-korn is a graduate, the MDs from University of Airlangga, Indonesia, and maybe one of the student or professors, Miftah. She have around 22 publications in the last few years with a high standard of the quality journals, and she also have a research grant from the governments and from the University of Airlangga. Today, Dr. Judith is going to talk about the pro-inflammatory cytokine expressions observed during HP infections, reveal the possibility reasons of the low-grade intestinal metaplasias in Indonesia. Dr. Judith, please.
Okay, thank you, ladies and gentlemen. First of all, I would like to thank you for my mentor, Professor Muhammad Miftah Husturur from Airlangga University, and also Professor Yosio Yamaoka of Oita University for mentoring this research. And also, I would like to say big gratitude towards Professor Ratha-korn for inviting me to this special moment. Ladies and gentlemen, today I would like to share with you our study called the Pro-Inflammatory Cytokine Expression Observed During Helicobacter pylori Infection that revealed the possibility reason of low-grade intestinal metaplasia in Indonesia. So as we know that Helicobacter pylori remains a major cause of intestinal metaplasia, or what we call the IM, that is associated with gastric cancer development. Indonesia, my country, is a very unique country which is consists of archipelago, which is an island country in Southeast Asia, comprising a very big population, around 270 million individual and more than 1,000 ethnicity. And interestingly, the Globocon reported that our incidence of gastric cancer in Indonesia was very low compared to other countries. This is also supported by the low incidence of intestinal metaplasia in Indonesia. This also correlated with our finding with the low prevalence of Helicobacter pylori infection in our general population. However, this finding varied among ethnicity. It consists from a 0% incidence toward up to 50% incidence. So the pathogenesis of Helicobacter pylori infection also involve the infiltration of inflammatory cells and also correlated with the production of the cytokines pro-inflammatory such as IL-8, TNF-alpha, and also IL-17. We also found that different host population could produce different level of cytokine response during the H. pylori infection. And it also could partially explain why some regions demonstrate difference in the incidence of IM, even though the prevalence and characteristic of Helicobacter pylori are approximately the same. So from previous study, many countries already performed a study and reported a high incidence of intestinal metaplasia. But examination of the incidence has not been performed in a country with a low incidence of intestinal metaplasia. So our study is, we would like to understand the reason for the low incidence and low grade of IM in Indonesia based on the cytokine expression and gastric biopsy specimen. So for the method, we collect the gastric biopsy from the subject, dyspeptic patient from Indonesia across our country that came to our hospital or an endoscopy clinic. From here, we can see that Indonesia is very diverse in race and also in culture. You can see there are so many characteristics of the people face and people culture, and even though the location is very near, but they have different language, different culture, and also different race. So we use the updated Sydney system to examine the histological scoring, and we use PCR for analyze or to conclude the genotyping virulence factor, and we also use the RT-PCR for the expression level of IL-8, TNF-alpha, and the IL-17. So from the characteristic of the study subject, the subject were located and we are collected in several cities with a predominantly ethnic, it's Minahasa and Papua, with 39% patient is detected as a positive H. pylori status, and with the majority of the gastritis and atrophic gastritis as the majority diseases. From the subject, from the histological finding, we can see here that the subject demonstrated normal to mild histological finding, which is corresponding to the mild, corresponding to the PMN, IM, and atrophic scores, especially in the H. pylori positive groups. And for the gastric mucosal expression, we can see that in HP positive subject, is very, all of the cytokine showed the significantly higher than the HP negative group in especially in any disease. And in here we can see the similar result were also found with all disease generally, the expression tend to be higher in the subject in the order of the disease gastritis, chronic gastritis, atrophic, and the intestinal metaplasia, regardless the H. pylori status. And then since our previous studies reveals there's a variation of gastric cancer risks among our ethnicity, so we analyzed the cytokine expression based on ethnicity. We can see here that even though in a HP negative population, the IL-8 is significantly higher in the Papua ethnic rather than in the Timor ethnic. And also it is shown in the TNF-alpha that the Papua ethnicity had a significantly higher expression rather than the Batak ethnicity. And if we look at the HP positive group, almost all the cytokine demonstrated a higher, significantly higher in a Batak ethnic rather than in Minahasa ethnic. So we would like also to check whether the from all of those results, we can see that there is a few major points, which is the cytokine is related to the histological finding, the ethnicity, and also the HP pylori status. So from this updated Sydney system, which has a grading score, we see that the expression of all cytokine was significantly correlated with all of the factor, all of HP density, PMN, MN, and the atrophy. And as we can see that in Indonesia, we know that the strain is kind of different, which is we have a HP virulence factor strain called the KA type. So we analyze whether is there any different genotypes that is associated with different level of cytokine expression. And we can see here, we try to make a correlation with all of the majority of virulence factor, such as KK, KPI, ICE, and also the FECA. But unfortunately, from the our results showed no significant difference in cytokine expression with all of those genotype of virulence factor. However, there is a tendency in the KA and in the FECA that is show a little bit higher. We can see in the next this slide that the cytokine expression associated with the FECA S1 M1 tends to be higher rather than the S1 and M2. As for the KA, we see that there's we check three KK type: the East Asian, the Western, and the ABB type. The ABB type, which is contain 8 base pair deletion sequence, it had the lowest IL-8 and TNF-alpha expression, and also this part is very interesting because the EL8 and TNF-alpha expression tend to be higher in Western type rather than the East Asian type, which we know that the East Asian type is the most virulent rather than the Western type, but at this result, it shows discrepancy. So, ladies and gentlemen, our analysis showed that the cytokine expression was significantly correlated with all degrees of histological finding. And generally, the results show a tendency for the association of higher cells and with the PMN, MN, and atrophic rates with higher level of pro-inflammatory cytokine. And this result was expected considering that pro-inflammatory cell infiltration could express or induce the expression of pro-inflammatory cytokine. And the study also showed the cytokine expression in H. pylori positive subject was significantly higher than in negative subject, regardless their disease and status and ethnicity. However, some ethnicity shows significantly higher cytokine expression compared to the other with the same infection status. And in addition to different ethnicity, the difference was possibly attributed to different KA types in both ethnicity. KA, as we know, is a virulent factor that can induce inflammation. And in our study, most of our strain is East Asian type, which demonstrate a 6 base pair deletion. And this deletion might contribute to the low virulence of the East Asia type. This what the example of where's the place of the base pair deletion is. And as our conclusion, that cytokine expression was significantly correlated with all degrees of histological finding in some ethnicity, and showed higher cytokine expression compared to other with the same infection status of H. pylori. And even though cytokine expression in Indonesia is generally not robust, although the subject predominantly demonstrate a KA East Asian type straight isolated from Indonesia, but still because it maybe can make a less virulence than other type because of the deletion in the preapia region that is might have a lower ability to induce cytokine expression that can lead to intestinal metaplasia. Thank you, ladies and gentlemen. We will free to answer the question.
So do you have any questions from the floor? I have one question for you. We know that sometimes the pro-inflammatory cytokines is maybe difference between each type of histology, just like in the intestinal metaplasias, for the chronic gastritis and the dysplasia. You think that the level of the pro-inflammatory cytokines may be one of the factors that can lead the precancerous lesions go to be the stomach cancers?
If I may catch your question, is the level of cytokine can lead to cancer? Is that correct, Professor?
Yeah.
Okay. As theory, it is, but it looks like in here we haven't compared it to other population that has higher gastric cancer incidence, because in Indonesia itself, the gastric cancer incidence is very low. Even though our dyspeptic patient is the highest patient that come to our hospital, but we cannot found the incidence of gastric cancer is very low, and the expression itself are compared to other our ethnicities that still has low incidence of gastric cancer. However, it still cannot be concluded yet at this time whether the level of cytokine itself can lead to a gastric cancer occurrence, but the histology that we found, the highest expression can lead to a worse degree of histological that maybe it can lead to cancer right away, but we still believe that there is another factor that included in this process.
Okay, thank you so much.